Hi, everyone. So my name is Jeff. If you haven't met me yet, I'm an M2. Maria and I are going to be moderating the session. So we have like a bunch of questions that you've already listed, but if you have any questions that come up, just feel free to unmute yourself and ask them directly to Dr. Menella. I'll start by reading like snippets of like her biography. Hopefully you've already kind of like taken a look at it already. But just as like a review, Dr. Connie Menella is internal medicine specialist and chairperson of the Department of Correctional Health at CIRMEC Health Services. It provides health services to patients incarcerated at Cook County Jail, the largest single-site correctional facility in the U.S., and the residents of the Juvenile Temporary Detention Center. And she was named Cook County Health's 2017 Doctor of the Year. Her hobbies include jogging, reading, traveling, obviously before COVID, and through talks with locals exploring how other countries view and address substance abuse, mental illness, and incarceration. She also enjoys family time with her husband, 3 children, and their spouses, and extended Chicago family.
Hey, everybody. Hi. Yeah, go ahead, Maria.
Yeah, I was just going to start with one of the first questions because I think it sets us up to hear more about your career. And as Dan mentioned, we haven't gotten so much exposure into correctional health, either from our curriculum side or training in general. So one of the questions that we got is, could you please describe how you first got involved in correctional health? And the second part of that question is, how can you advocate for incarcerated people using your position as a physician?
So great question. And my path started at Northwestern. So I was a Northwestern med student, like you all here, from 1984 to 1988. And I could remember this day so vividly. It was 1985. It was a class called Introduction to Clinical Medicine. And the time I was in medical school, it was very much the first 2 years you were in a classroom, hardly any patient contact. And then, you had to wait till your 3rd year. So whenever we had any exposure to real medicine, and, not just the classroom activity, we all perked up. So here was Introduction to Clinical Medicine, and the lecture was given by the medical director here at the Cook County Jail, also a Northwestern University Medical School alumni. And little did I know this was going to be my career mentor. So the lecture was intriguing. It was absolutely an introduction to the world of correctional health, and it was pretty focused on the public health opportunities in corrections, and it was full of, slides of gonococcal urethritis. Just so much medicine was packed into this lecture, and there was an invitation to come to the jail if we wanted to. I didn't actually take up that invitation. Many of my fellow classmates did, and they remind me of that every 5 years at the reunion. So it just planted a seed in my brain. I knew I wanted to do primary care. I knew I wanted to do urban medicine. I'm a city girl, and born and raised in Chicago. And I really didn't think much of it after that lecture. I will be honest. I really did not think that day, oh, this is what I'm going to do the rest of my life. Now you got to fast forward. I'm an Illinois Department of Public Health recipient. I don't know if they still have that for medical students. So while I was at Northwestern, I was granted this scholarship because I committed to what I knew I wanted to do. I wanted to care for a vulnerable population. I wanted to do urban medicine. So fortunately, I was granted this scholarship, and it allows you to finish training in a primary care or psychiatry. So I finished my internal medicine training, and I then had to choose a site to do a 3-year payback for the Illinois Department of Public Health scholarship. And there I saw, Cook County Jail, Dr. Jack Raba, still the medical director there. And I said, this would be great. I'm going to have 3 years inside the jail. Probably many of my patients that I'm going to care for in an urban, clinic are going to come from the jail. This will be truly a great introduction. That was 1991, and I never left. So it's not a path that I knew I was going to take in med school. I didn't know I was going to take it in residency. And I feel so fortunate that I had that exposure in med school. And it makes me sad to hear that there's nothing in the correctional curriculum about correctional health, because from 1991 to 2007, I participated. There was actually something called vulnerable groups at Northwestern, and I had students every quarter come to the jail. We had a big transition in Cook County in 2007. This is probably too much information, but the transition was so big at Cook County Health. They felt like there was too much care at the jail, and they reduced positions, and my position was removed. So, and this is a great opportunity to tell you guys, things are going to happen in your career that you don't predict, that are not always under your control. And little did I know that move, which I was the associate medical director, that was kind of the key word. All associate positions were removed. But what they did is then remove much more from the jail than probably they should have. And the jail then went into a consent decree. So here I'm home. I was actually lecturing at Northwestern while I had a little family sabbatical it wasn't very long. And then I got called back when it was very evident that the cuts that they made at the jail, but I think we never really resumed the vulnerable groups population lecture. So a long answer to a question, but really the path was one thing led to another, and it's true, there is no residency in correctional medicine. So that's why it really takes kind of extra effort to learn about correctional medicine. So I appreciate this opportunity to talk to you guys. I try to take advantage of meeting and being with students whenever I can to expose them to this. So look forward to more questions and learning a little bit more about what I do. Does that answer questions, that question?
I think so. And I think to the second part, something that seems to be a particular theme in the questions is how as medical students or as physicians, we can advocate to improve the health of inmates or formerly convicted persons.
So this is really interesting, and it's, I guess I'll segue right into, first of all, I feel really honored and privileged to have had this career. It's been unbelievable, not just professionally satisfying to, again, my mission and going into medicine was to serve a vulnerable population. And I don't think I'm being melodramatic in saying that this is one of the most vulnerable populations that anyone can serve. And it's been a humbling experience. And little did I know when I started this career that we were at the beginning of mass incarceration in the United States, and that a prison industrial complex was beginning. And perhaps if I knew that, I would have been, no way, I'm not going to be a part of this. Instead, I was here. I saw very sadly what injustice does, and what created the mass incarceration. And I think that because I kind of lived through it, and I, as a physician and being part of this amazing group of providers here and within Cook County Health, we were always very mission driven. We didn't hire or recruit people unless they had that mission-driven philosophy and commitment to serving this vulnerable population, that we have been advocates from day one. Unbeknownst to us, it's kind of a part of just what we do in treating our patients and seeing them as patients and treating them humanely, but also having the opportunity to advocate for them. So so I'm talking 30 years, right? I've been doing this for 30 years. So when I started my career, I'm just a boots on the ground physician. I went into management pretty early. I don't know why. I guess I was full of energy, and I became kind of a leader early on in my career here, but always maintained that I was going to see patients. So advocacy comes in many ways. Advocacy comes in your professional life and in your personal life. And if you ask any family or friends, they know this. And I could not advocate for my patients even when I'm at a PTA meeting or I'm in my community and someone says, what do I do? So any opportunity, it was from day one, I felt like I was destigmatizing this population. These are men, women, you know, especially at the beginning of the mass incarceration, the only thing that distinguished so many from us to them was because they didn't have money to bond out. They were poor. So there wasn't, there's, you know, humanity, I think, viewed people who were incarcerated because of the media and because of fear. And I saw it and lived it every day. These were, you know, and these are men and women that unfortunately, due to injustices, are incarcerated, or due to stigmatizing of mental illness and substance use disorder. That's the means at which they got incarcerated. So, and advocacy comes in just not only the care and treatment, but we started becoming involved with justice reform. And justice reform has been a long time coming. Thankfully, we are seeing some of the effects of justice reform with bond reform. So when I first started here, if you were a crack user, you could get a tremendous sentence, but if you were a cocaine user, and that's very distinguished people socioeconomically and racially, you may have had a low bond. So we were, as healthcare providers, we weren't only involved with caring for our patients and delivering, you know, good quality care and making sure that our patients had access to care and transitions to care. We also got involved with justice stakeholders. So I think the most important thing that we're doing now, and I think it is getting some traction, there is the conversations happening, but there is justice reform in trying to look at, you know, how did the United States get to this position? How did we mass incarcerate? And that's a lecture in and of itself that I often give to med students. You know, we closed down all the mental health institutions in the 80s. And, you know, we had no infrastructure in our communities, so we incarcerated them. So now we're really advocating for the mentally ill. We've criminalized a chronic medical illness called substance use disorder. So, you know, and these are the things that we are not only personally am I getting involved with in my administrative role, in looking at justice reform and partnering and seeing how we can support our patients in the community. So that's another long-winded answer. But it's, and when I talk to med students, when I talk to residents at Stroger Hospital taking care of our inpatients, you know, they'll call asking questions, the most common answer is, what would you do if they weren't incarcerated? It's treating patients like you would in any other scenario. So it's really about destigmatizing. These are men, women that unfortunately are behind bars right now, but they're part of the community.
And everyone, again, I have questions set, so I'll try to bring them up as the conversation flows. But if there's anything you want to bring up, please either write it in the chat and we'll try to read it out, or just unmute yourself. But Dr. Menella, you mentioned in your answer a little bit about substance abuse. And one of the questions that we have also deals to the opioid crisis that the United States is currently experiencing. And one of the questions that our students wanted to know is, what are the key barriers for prisoners receiving adequate care in terms of pain management? And do you feel that prison providers are not providing standard of care in that sense?
So for semantic purposes, and I say it because our patients are even sensitive to it. So I am here at a jail, and jail is pre-adjudication, or so people who are awaiting adjudication, awaiting conviction. And believe me, you know, again, our patients are sensitive, even though philosophically, I would do no difference for someone who's in prison. But just to let you know, so this is the Cook County Jail and that prison. So the Cook County Jail is unique. Healthcare is provided. You know, obviously that's what I'm here talking about. But I am part of a huge safety net of Cook County Health, so Stroger Hospital and the Cook County Department of Health, a very large safety net. So we are pretty unique that we have been very supported with a mission-driven healthcare delivery system who really values these our patients and our mission. So I would say what we've been doing is really addressing the gaps in the community we see magnified inside the jail. So those gaps of mental health in the community that come into the jail. And we have really been at the forefront of substance use disorder treatment. Just to give you an example. So again, I feel like we've adjusted and changed our model of care to really meet the needs of our patients. And absolutely right now, one of our biggest focus besides COVID is meeting the needs of substance use disorder. We started, we were one of the first jails in the country to give medication-assisted treatment in a jail and to train our patients on Narcan and to give patients Narcan the minute they walk out the door. And we've been doing this for years. Took a lot of work with working with the sheriff. Narcan was only delivered via a needle at the beginning. So as soon as we got the nasal atomizers, that's when we really were able to implement our plan. So interestingly, when we started giving medication-assisted treatment, and we were really using a chronic disease model with our patients, we started educating judges. We found that the community couldn't keep up with us. So we would start patients on Suboxone, Vivitrol, Methadone, or continue from the community, but we couldn't find community providers to hand them off to. And there was payment issues. So it really required the community, thankfully now, has so much more capacity to treat substance use disorder. It's treatment is being accepted by more judges. If I told you how many times people would come in and the judge would court order someone to be detoxed off of methadone because they dropped dirty, and I don't know why I haven't been put in contempt of court, because we defy court orders. We will challenge it and say, no, first of all, you're not a doctor. And no, we're going to talk to our patient, and our patient's going to tell us what we're going to do. So thankfully, with lots of education to judges and whatnot, things have changed. Though it's really handled very differently by different judges. So that's, again, another example of advocacy. We will literally go to the point of defying court orders, just staying focused. What is the right thing for this patient? Giving that patient the voice. They have the same rights as any. In fact, they're the only citizens in the United States who have a right to health care. And they have those rights, and we let them choose. So that's again, another example of advocacy. So now, is jail care and prison care the same in every jail? No, absolutely not. Does every jail have the same resources we do? No. And again, when I talked about 2007, it was bad. They got rid of staff. They changed the model of care. Just that impact alone took us years to recover and come back. We went from best practices with our, with our model of care, and it was slashed. And we actually, Cook County got sued by the federal government because our patients have a right to health care. So it's the saying goes, when you're in one jail, you've been in one jail, because every jail is different and every prison is different. So there's a lot of medical care in jails driven by litigation. We were unique as a large urban jail that we did not report to the sheriff. We have a really good sheriff here, but not every sheriff is as progressive. So I think what's really important, and I think is what has kept me here for 30 years, is we are autonomous and we report to a health system. We don't report to a jail. And that LA and Rikers in New York used to report to the sheriff. Now all 3 top jails report to a healthcare. And we were kind of the lead in that and demonstrating that that's really how it should be done. So that's.
So we have a question from the chat, and it talks a little bit about that difference between jail and prison. So could you talk about general differences between what services are provided in jails versus prisons, if there are any differences?
Yeah. So, wow, this is like my lecture I usually give. Next time I'll have slides. So jails are supposed to be temporary detention centers awaiting adjudication. Sizes are very different. Again, this is the largest urban jail in the country. We have a census right now of about 5,500. In 2014, we were 12,000. So we're on a very expansive campus. LA and New York are the other 2 large jails. So you could have someone as large as like top 3 urban jails, or you could have a jail of 100. So they're so very different. It's regulation is often none, and dependent on the sheriff, and dependent on the county, and dependent on politics. There's not regulatory body like, you know, hospitals have regulatory bodies like JACO, and you have to follow rules. So really, jails and prison care have been driven by litigation and lawsuits. There have been some attempts to regulate. There's a National Commission on Correctional Healthcare, but there's no mandate to do such. Prisons are meant to have longer stays, and the big difference is the jails really have a burden of every day, you know, 365 days a year. I think I could think of one day where we didn't get anybody. It's because the city was shut down by a snowstorm and no one can travel in the city. We have new people coming in the jail off the street. So withdrawing from substances, chronic medical conditions that haven't been addressed, you know, add pregnancy and withdrawing from substances, tremendous amount of healthcare burden that they don't come in with records. They come in on the new. It's probably the lowest point in their life. And we have this daunting task. And this is something that we pride ourselves on, because unlike other jails, which can wait days before seeing someone, we see them the minute they walk in the door, and we start that assessment and that integration into healthcare and treating them right away. So by the time they go to prison, we've already taken care of that serious mental illness, hopefully gotten them on meds, stabilized. We've taken care of their chronic illness. So they've had care, and they go to prison, and they come with medical records. So there's a really different responsibility and model of care. So we're really dealing with a lot of unknowns and acute and stabilizing. So the prisons are longer care stay, have more to do with, have more elderly patients. Usually jails are a bit younger. I would say though, that is changing. We have people in the jail now that have been here years. We have aging sex offenders that can't find nursing homes. So I've, 30 years being here, after sex registry laws were put in place 30 years ago. Now many of these sex offenders are aging and they have dementia. So the jails are actually now starting to care for older patients. Jail stays are much longer. What used to be, it's kind of a bimodal curve. Half the patients were gone within 14 days. And then if you were here, maybe you were here for months or a year. It's much longer now. So we've had people who were here 10 years. So the difference is based on the time and discharge planning, right? I never know when someone's going to leave. A judge hits a gavel, they're out the door. So a prison will have an end date and prepare for that transition of care and have a lot of time. We have gotten so creative because we know we're not going to get advance notice. So our discharge planning starts at intake when they first come in and they sit in front of a doctor, sit in front of a nurse. We start having that conversation. We actually do an insurance check and enrollment on day one to prepare for the discharge that we're not going to have any advance warning on. And we'll, you know, have the conversation, tell our patients what to do. And we've created interesting alerts. We're 100% electronic in our system that alerts us when someone's discharged, so we can prescribe their meds or make the phone call or trigger something. So discharge planning is very, very difficult in a jail, easier in a prison. I think we've spent so many years really focused on care while someone is in custody, and really proud of our, substance use disorder treatment, gender affirming care, mental illness, our chronic disease management, all this robust oral health care that they can't access in the community. And now we're focusing on kind of the before and after. How can we advocate for reentry? Don't put them in jail. Instead of, have crisis centers to divert. And now we're also looking at that transition to care once they leave. Can we do something as they leave or after they leave to prevent, recidivism, to stop this cycle of coming into the jail? So, yeah, it's a great question, but a big difference.
Oh, you're muted, Ellie.
I have a question. Can I interrupt?
Yeah.
Okay. So I've been really inspired by you speaking on how much you've been able to be an advocate for your patients. And on the flip side, I'm wondering if you can speak to if there are points in your career where maybe you felt powerless. And if so, I can just imagine that working within a system that's so riddled with injustice, that there might have been instances like that. And if so, how you cope with them?
That's a great question. And I think when we talk about substance use disorder, and especially substance use disorder and mental illness, it's so frustrating that to this day, we are still incarcerating patients with substance use disorder. And during COVID, the judges decided, or someone thankfully said, oh, we can't, we're not going to collect that urine. Everyone's afraid of contagion. So they stopped drug screening people out in the community. And we were thrilled because you know how many years in legislation we've been trying to advocate that someone who drops dirty or someone who relapses, they shouldn't be reincarcerated. That's the worst place to put them. They should have, wraparound services in the community. This is showing that it's just like any chronic disease. You have a diabetic who, doesn't take their insulin or eats their cake. You don't punish them. So it's been frustrating for me to see the punitive nature of chronic, of looking at substance use disorder and mental illness. That has been frustrating. And, are we making improvements? Not, to me, not fast enough. So when I talked about it, I feel silly that it was in my little bio, but I am serious. When I travel, and my kids know it, believe me, my kids are all justice for it. My kids know it. Any cab driver, any whatever, wherever I'm at, I will say, so can you tell me what you do? Like, what if, you get, you're using drugs on the street, what happens? And how long do people, get sent to prison for? And they're like, prison? What? And you'll see just how other countries have done it. How mental illness, they don't incarcerate. Like, we as a society have created such a vicious cycle and such, it's societal, it's a damage to the fabric of our society that we have criminalized mental illness and substance use disorder. And I'm telling you, if you are demented and you have dementia, you are living in an area that there's not a lot of resources, and you are, you know, 75-year-old man on the street exposes himself, you're in the jail. You're in the north suburbs or somewhere else, and it's an older, you know, man with dementia that exposes himself. They'll call the family, take him to a hospital or whatever. It just astounds me that we are still criminalizing and not understanding, and that there's disparity still. There's still definitely disparities. You know, is there a lot of work with the police departments, with crisis intervention? Absolutely. There's a lot of good people out there. There's a lot of good people who want to do a good thing, but we have gotten ourselves so deep into this cycle that it's going to take a while. It's going to take all you guys. It's going to take all the, you know, really to get us out of it. So that's probably my biggest frustration. I mean, delivering care in a jail is daunting. Our patients can't pick up the phone. So you can imagine the anxiety is just not for me as, you know, a leader of a clinical leader here, but my staff. You know, we have a different threshold. So we may see our patients more often. We may be more, concerned and have a different care plan than, let's say, someone would out in the community, because our patients rely on us to advocate for them. Can our patients have to do is they're in a cell, they have to advocate for themselves and get an officer that believes them, and then that officer take them and put them in front of a provider. So what I've done here, what was more important for me to do, or not more important, but I really had to form a really tight collaboration with corrections. And I had to empower them that there's no barriers for any officer to bring someone in front of a healthcare provider. You know, many jails will do that. You have to, you know, call a nurse or do something. We tell them, no threshold. You know, false alarm, no problem, don't worry. So we have 24/7 physicians here in urgent care, because when we don't have that, you know, our patients, again, don't have the same access as the community does. So it can be very scary and daunting. And is it perfect? Does it work 100% of the time? Do you control everything? Can you control every officer? Can you control every behavior? No. And that's difficult, because you don't only feel responsible for the care that you recommend, it's for all that other things that you don't control.
You also brought up a little earlier COVID-19 and how we've had a positive change based on COVID in terms of drug testing. But some of our participants wanted to know what the process has been of controlling COVID-19 and maintaining your patients safe while they're in Cook County jails.
So what a ride this has been. So starting in January, as soon as it was evident COVID had come into the United States, we started preparing and planning. And, we lived it just like you all received the same news. When we have a large jail collaborative that all the medical leaders kind of get on it. We've had this for years. So early on, we joined together for best practices. CDC had no guidance for us. And we all kind of got together. We started collaborating with our, correctional partners. And what we did is leverage what we know. And as correctional leaders, we've got a lot of experience, and we have a lot of experience dealing with infectious disease and, inside jails. Fascinating to just have been a part of that. So we had in place really robust infection control plan, because you have to. You have congregate areas, and if you have a case of salmonella, I can tell you our experience with salmonella when salmonella hit the jail. Norovirus, it's like a cruise ship. So influenza every year. So we had these very strong infection control practices, but we knew that it would have to be more than just that. So we followed the community standards. What was the community standard saying? Social distancing. Remember, masking was that off on, off on. But we started changing what the jail looked like. We went from 12,000 to 6,000. So what the sheriff did is say, okay, we're going to open up all those jails that have been closed and let's spread out our detainees. So we, again, prepared. And then it was the first week of March where I'm on the jail collaborative call, and Rikers Island, it was just one of the most depressing, absolutely the most depressing call we ever had, but it had hit Rikers hard. And they said, guys, we can't believe it. We did everything, and we went from 0 to 50 to 100, doubling every day. When I heard that, geographically, Chicago follows New York in just a matter of weeks. And so we always knew, and all, you know, again, especially New York and Chicago, because we were seeing, remember, Chicago had one of the first cases of transmission in the community. So we knew it wasn't going to be if, we knew it was going to be when. So that kind of gave me, okay, it's about a week away. Remember the dialogue in our country, was there any testing? Did anybody in the community get testing? Hospitals really weren't testing. We were isolating. We had a uptick in our influenza-like illness. We were suspicious. We were compelling the state to let us, we had to beg for our first test because it didn't fit the criteria for COVID. And lo and behold, just like Rikers, it hit us and we surged. So we had a absolutely, as soon as our testing availability came in, all those patients we had in isolation, 90% of them were COVID positive. So we just did what we did, really, again, sheltered in place, used strong infection control practices. Everybody was talking about flattening the curve, but we stopped it. And we have maintained our containment after that initial surge. The initial surge was horrific. We had already asked for increased staffing because we had spread our footprint so wide. We had increased staffing. I mean, again, that's a whole nother lecture too, but it's been a daunting, and I can honestly say residency was a piece of cake when I look at my life in March and in April. You know, you bond when you're in the battle, in the trenches together. So the sheriff and sheriff's office and I, we really bonded, but we did it together, and we are continuing to do it together. We're in containment. Containment for us means 1,500 minimal tests a week, because the community comes into the jail every day. I can't stop it. There's no shelter in place that's going to prevent officers from coming in and bringing COVID, preventing it. The community comes into the jail every single day. So now, thankfully, we're all about containment. And the sheriff actually sent, you know, once in a while we pat each other on the back and say kumbaya, and it's so great to work with each other, because as the city is surging, we're, knock on wood, we're still containing, because we are putting out fires every day. We know it's basic infection control. And when you surge, it takes you a while to kind of get that under control, and we did. And now we're just putting out the fires every day. Actually, the Chicago Department of Public Health appreciates, we're kind of the canary in the coal mine. I know some of the people want to call us the petri dish. Absolutely, the surge, that was the experience. But now we called them a few weeks ago and said, we've got so many intake paths. These are young people. They're all asymptomatic. So what we do now, our 1,500 swabs a week are every person who comes in the door gets a rapid. We were one of the first people to use rapid tests in the city, gets a rapid, and they get a follow-up test. And we do, I mean, it's a myriad of protecting our vulnerable population testing, and really intense contact tracing. So we saw those intake positivities. Is anyone testing our patients in the communities they come from? Probably not, but when they come into the jail, they're getting tested. So we saw the surge. Thankfully, we can, you know, it didn't surge us because we tested them as they came to the door. We isolated them, They never infected our general population, but we warned the city. I have to say, there was another, one of our earlier surges, we warned the city, and then the city put out like they pushed back a restriction. I was like, oh my God, that's our fault. Because it's really, they understand that we are kind of the canary in the coal mine. So it has consumed me even to this day. So yes, we are definitely working really hard still to maintain.
Yeah, and switching a little bit from topics, there's this really interesting question about patients needing specialty care in correctional facilities. So what is the process of these patients needing care and being able to access it? And the person that initially wrote the question was thinking specifically things like ophthalmology, but just overall specialty care.
So here is my, again, our patients warrant the same access to care, whether they're incarcerated or not. So we have just our CIRMAC staffing in general is about 700. And so in our CIRMAC staff, we have psychiatrists, psychologists, we have optometrists, and we have physician, nurses, and we are also, remember, part of Cook County Health. So every specialist at Cook County Health is responsible for caring for our patients. Some of those specialists come here, so urology, cardiology, I'm going to forget, dermatology, ophthalmology, orthopedics. I know I'm forgetting. Does neurosurgery come here? No, because, you know, just by the numbers and the volume. So if it's a specialty service that our specialist doesn't come on site, which is ideal because they don't have to be transported and they don't want to be transported. Who wants to be in shackles and get on a van and go to a clinic? So if it's something, though, that's not here, they will get transported right to Stroger Hospital and get the care there. So inpatient, we're not an inpatient hospital. We inpatient care needs are also serviced over at Stroger Hospital. So yeah, we have a very, very robust, we have a CAT scanner, we have stress tests, echocard. It's a really robust healthcare delivery system, a 24/7 urgent care. So yeah, very robust here. And again, not like a lot of jails in the country.
And I know we're getting close to our time. So for anybody else, if you have any questions, just send them my way or ask them out loud so that we make sure to get to them. But we had another question about providing care for injuries caused by law enforcement. So how is that experience for you at the Cook County Jail?
Yeah, so like I said, we see patients immediately when they come in. And absolutely, our patients may say, I had an injury while I was arrested. We will obviously do what we have to do. We consider ourselves kind of just like with DCFS and reporting for children. If we get word that someone reports they had injury because of excessive force, we have a system in place with the sheriff's office that we have to report everything. It's a really intensive investigation. The jail has used cameras for years, and that has been a tremendous cultural change. So, you know, when I talked about in 2007 and they kind of got rid of services and then the feds came in and sued, that was one of the things that was really addressed was this excessive force and use of force. And so early on, there was a mandate that all the officers had to wear cameras. And I kept thinking, you know, when I'm hearing about everything that's happening in the city, you know, why isn't the city wearing cameras? So now, you know, now the city has cameras, now there's change. And I have to say, what we saw here is a pendulum swing. So the cameras were worn. There was this mandate, we are mandated reporters. And believe me, when, you know, that officer is not only responsible for, you know, law and order in the jail, they're responsible for my safety, and I'm going to report them. So you can imagine that could be a situation that is a bad situation in many jails. But when it's a cultural change that everyone understands what is right and what is wrong and what's going to be addressed as the, you know, use of force, it really changed the culture here. So cameras are warned, and we're part of, we will hand over records, and we'll hand over, you know, if reports if someone has use of force. Dr. Reba, who was the medical director at the jail and the Northwestern alum, if you Google him, he was the main witness with the John Burge Chicago Police Department torture cases that brought a lot of Chicago Police Department reform because of that intake evaluation. And he saw radiator burns on a patient's body. This was back in the 70s. It preceded when I came here. He reported that. Unfortunately, his reports and action were hidden until 30 years later, where it was uncovered and he was actually a witness there. So I started at the jail with that as, you know, this was my mentor, and we, you know, we used to, here I'm whispering, we used to have books in the urgent care, like if an officer came in and had an injury to his hand, we would put it in a secret book and then report, because, okay, why does an officer have an injury on his hand? And we would report it. And then if we saw a patient 2 days later who was injured but didn't want to say who injured him, we would kind of connect the dots and report it. And me just telling you the story, it's like, really? I worked under those conditions here. So, you know, I think someone asked that question, is there anything that, you know, I question, you know, being a part of the system and the ethics or whatever? It's probably something like that. Like, really? And it seems foreign to me because it has changed tremendously over the years. But when I first started here, yeah, I guess I stayed though. I think I stayed because there was so much good that we were doing, but it's hard to even tell the story like, wow, I saw that. And yeah. So thanks for asking that question.
And I think just likely for our last question, what is one thing you wish you knew about your specialty that you didn't know coming in?
So my specialty is internal medicine, and you know, as we already said, there is no correctional medicine specialty. And I'm really glad I didn't know much about it. Like, even telling that early story, you know, would I have gone into that if I knew that was the environment? No, I probably wouldn't. In fact, Dr. Reba and I did a podcast where we talked to each other, and it's like, you know, should we have done more earlier? Like, you know, reminiscing about that. So I am grateful that that I had this path in correctional medicine. I kind of had this opportunity. I worked with tremendously dedicated people, and you know, Cook County Health is really mission driven. It's, you know, probably not everybody could work in that environment, but I'm grateful that I kind of went into it and really was able to maintain my initial you know, passion to work for a vulnerable population. It is the same as it was 30 years ago. I don't feel jaded. And believe me, when I go to my every 5-year reunion, I don't see that in all my colleagues and my colleagues and my fellow classmates rather. And they're so cute because they're always it's like, Connie, tell the story. You know, everyone's kind of intrigued with my career, that I am grateful that, you know, I've kind of had this journey. And I can say 30 years later, there's still so much to do. I still feel like I'm not done, and that I am, you know, going to pass the torch to a tremendous, great group of providers that are here right now. Sometimes it's good, you know, to just push through that journey, experience it, and just maintain that basic passion. If you're not feeling that, if you're getting jaded, if something's wrong, just I think it's really important to be able to professionally experience that. So yeah, I'm great. I'm really grateful.
All right, looks like it's time to wrap things up. So if anyone has any last minute questions, feel free to ask right now. You can message in the chat if you don't want. Yeah, I think you have a question.
I just have something kind of more broad, but you mentioned a lot about how Dr. Reba, his findings were buried for 30 or so years, and you talked about a lot of the frustrations of working with the system and trying to change how people perceive the incarcerated populations and some of the policy barriers. How do you kind of work with that and get people to really care about the incarcerated population and get the funding or the resources and the attention that it needs in order to make some of those changes?
So again, I have the advantage of being part of Cook County Health that has the same mission I have, so at least I'm not battling that, at least since, you know, post 2007. So that's really great. So right now, I probably spend more time on safety and justice challenge. I've got a lot of opportunity working with justice stakeholders right now, and including policymakers. So that's part of my day also, is looking at, so, you know, I talked about something simple like drug screening. We sent something into legislation to try to advocate to really get it on the books to stop this. So it is working on all of those lines, working with justice stakeholders, working with lobbyists, politicians, working with talking to fellow medical students to, you know, just to destigmatize the incarcerated. So it's all the lanes right now, and I feel again privileged that in this time of my career that, you know, I love taking care of patients. I still see patients, though I'm able to now have the audience, because we did not have the audience with the justice stakeholders 10, 20 years ago. You did not have an audience, did not, you know, and again, even within the health system, did not have an audience. I'm feeling, I'm going to be hopeful that we're starting a trend that we were going to see some change. So that's kind of what we're doing right now.
Yeah. Also, I was wondering, is there a way as medical students that we can get involved now with either helping those that are like currently incarcerated or like formerly incarcerated even?
Yeah, so that's a great question. And, you know, we have partnered with medical schools, and again, Northwestern, we've partnered with the women's health and even education for our patients with various medical schools to come on the tiers. So we're always looking for formalizing relationships. COVID right now, everything is on hold. That being said, that you know, that doesn't mean that something cannot happen. I think I love innovation. I like ideas. I like proposals. And, you know, we're always kind of open to it. I think a lot in terms of resources coming into the jail, it's going to be a bit because of that stinking COVID. But that transition to care planning, you know, right now we're trying to work with our community partners. So like if I heard that there was some community resource that somebody wanted to let us know to tell our patients on the way out, absolutely. You know, if there's resources out there, we would love to be able to give that to our patients.
That sounds great. Thank you.
Yeah, thank you. And Dan has my contact information. If anybody, you know, has any need, desire to contact, please don't hesitate to. I'm really excited for you guys. Medicine's a great career.
Thank you so much for offering that. And I will share Dr. Menella's email with you guys tomorrow, as well as the recording, in case you want to share it with any other student.
Oh my God, recording! I don't want to hear myself.
Oh no! Well, okay. I will share Dr. Menella's email with you guys. And anyway, I just want to say a few things here. Before we close. First of all, thank you, Maria and Jeff, for moderating, and thank you all for being here.
Thank you.
At the top of the hour, I let you guys know that I was excited to feature correctional health for the first time in this series because it's such an important field of medicine. But what I didn't tell you is that, specific to Dr. Menella, I was really excited to bring you guys together to show you a really profound example of a doctor who does what she loves. And I've done 90 of these in the last 6 years. And if you ask me, what is the thing you've heard doctors say more often in Alumni Physicians of Feinberg? It is, do what you love. Find what you care about the most and do that. You guys have infinite opportunities, and so many years ahead of you. But this is, medicine is wonderful, but it can also be, devastatingly difficult, and there's so much burnout. Look at Dr. Menella, she's 30 years in. You think this woman is gonna burn out? And this is tough. This is what's more emotionally tough than this type of work? So she found the right thing for her to do. And that's what I want to leave you guys with. I don't care if it's, sitting at home being a radiologist and looking at scans, then if that's the most thing you're most passionate about, that's what you should do. This is why I wanted to have this conversation. So please keep that in mind. And with that, I think that's my way of honoring and saying thank you to Dr. Menella. Thank you so much.
Thank you all so much. Thanks, Dan, so much. Really appreciate the opportunity.
Fantastic.
Great.
All right. You all have a great rest of the night. And I hope to see you at the next one, which won't be until December, actually. It'll be Dr. June McCoy from Northwestern Geriatric Medicine. So that's gonna be a great one. I'll see you guys. Take care.